Welcome everybody to today's plenary session. Today's plenary session is sponsored by the Human Services Research Institute. Leanne Kandura will introduce today's session. Following her remarks, Vinita Bahl, our moderator, will take over from there. Leanne?
Thank you, Norm. It's such a pleasure for our organization, Human Services Research Institute, known to most as HSRI, to be sponsoring this session. HSRI is a nonprofit, and for nearly 45 years, our mission-driven organization has partnered with government leaders, payers, providers, data organizations, and people who use health and human services to improve those systems and services. More specifically, our population health team develops and maintains non-proprietary data collection and reporting systems, data quality improvement procedures, custom analytics, and healthcare transparency websites. This year's conference is coming at unprecedented times and has highlighted specific challenges for individuals encompassed within HSRI's mission. We have reaffirmed our commitment to working with cities, counties, states that are actively looking to make their systems more equitable and to ensure that people's individual voices are heard and respected by those service systems. Today's session, Bridging Data and Policy, Evaluating the Impact of Data, is closely aligned with our team's commitment to not only build high-quality data intake systems, but to also use those data to ensure us of high quality so it can be confidently used to answer policy questions, enhance health systems, and publicly report the information to improve transparency. We are so fortunate to partner with our clients in Colorado, Maine, New Hampshire, and Oregon to help bridge the gap to use data for policy. There's no one better to moderate this session than our client, Vinita Bahl, VP of Data Analytics at CIVHC. CIVHC continually uses data to support policy efforts, and today's session and panelists will undoubtedly shine a light on how that's being done. Vinita?
Thanks so much, Leanne. That was a fabulous introduction. We have 3 presentations during this session, and in order to reserve time for questions, I'd like to jump right in and introduce our first presentation from Valerie Hamilton of BerryDunn, which is a management consulting firm. Her presentation is entitled Mental Health Parity and Provider Reimbursement. Valerie is a senior health policy manager at BerryDunn. She conducts policy analysis, including legislative and regulatory reviews on a wide range of topics, but much of her time is spent on behavioral health related topics. Valerie?
Great. Thank you so much. I'm going to share my screen here. All right. I'm so happy to be here today, and unfortunately, Andrea Clark, whose name is also on this presentation, is unable to make it today. She doesn't feel well. So the policy person will be giving the entire presentation, but it's something that I've done many times before, and I look forward to doing so today. I'd like to kick off today's presentation with some background information on federal mental health parity law and its requirements. I believe this presentation is very well timed, as access to mental health services has never been as important as it is today in light of all the stressors related to COVID. Since mental health and substance use disorders is such a mouthful, I'm going to use the phrase mental health services to include both, unless I note otherwise. For the most part, parity for mental health services means that health insurers and group health plans must provide the same level of benefits for mental health services as they do for med-surg services. At times, it's very obvious when carriers do not, but more frequently, the disparities are subtle, and even subtle noncompliance with parity can lead to real problems for access to mental health services. In 1996, Congress enacted the Mental Health Parity Act of 1996. It prohibited plans from imposing less favorable annual or lifetime limits on mental health benefits than med-surg benefits. The law brought attention to a very important topic, however, it was limited. For example, this first federal law did not provide any protection for substance use disorder services. For the next decade, several states passed mental health parity laws at the state level to try to give more teeth to parity requirements, And in 2008, the Mental Health Parity and Addiction Act went much further. While the 2008 law did not require that plans cover mental health and substance use disorder services, they required them to supply them at parity if they chose to supply them. So a plan could have a benefit package that did not include these services, but as soon as they included any services, they needed to supply them at parity. However, when the Affordable Care Act came around, the Affordable Care Act made mental health services and substance use disorder services essential health benefits. And so once they were required to be offered at parity. Determining compliance with parity includes two different kinds of tests. The first type, QTLs, is a test of the limits that are numerical in nature, such as visits or co-payments. And I'm sure for this audience, this would be no problem whatsoever. However, today we're trying to take a look at the non-quantitative treatment limits and looking at how data analysts can help policy individuals like myself identify red flags, not necessarily determine compliance, but identify things that just aren't quite right that warrant a deeper investigation. So these, on the right-hand side, these are limits that limit the scope or duration of benefits in less direct ways. So the test for QTLs is more straightforward since it's quantitative and more black and white. However, the NQTL test is really kind of evolving and there's a bit of subjectivity to it. But what it really wants you to carrier to do is look at how the benefits are written, all the processes, the people, the education level of the people making decisions, how long of notification is needed, and all those details that would be put into a policy and procedure. But on top of that, they want to make sure that how these things are written are how they're operationalized as well, because oftentimes there's a disconnect with the two. And so the test requires the carrier to audit the different procedures that they have to make sure that the time limits, for turnaround time, say for prior authorization, are comparable. They look at denials to see if perhaps mental health services are being denied more frequently than for medical surgical benefits. So, so the test is a little more difficult to apply just because it's a little less straightforward. So these are some examples of NQTLs, and the list certainly isn't exhaustive. Since it is anything that can limit the scope or duration of benefits, there are countless things that could be in a list. You'll find if you do a search or look at the final mental health parity rule, every list you'll see will say this is not an exhaustive list, because there are just numerous ways that there can be discrete ways that could potentially affect access. So because of time limitations, let's just take one, fail first policies. An example would be that a member only gets smoking cessation therapy once a year, but the carrier has no such limitations for medical surgical medications. For example, they don't give one course of antihypertensives and say, your blood pressure is still up, that's all you get. So of course they wouldn't do that, but when there are these limitations, what an examiner would say is, show me on the med-surg side something that is similar to this, and that you approach this in a comparable way than you would for med-surg. So why does mental provider reimbursement matter? These are all in a blue box. They're all NQTLs that impact network adequacy. We today are going to focus on the unreasonably low rates for mental health services, but all of these, such as prior auth, non-disclosure, contract terms, medical necessity standards, they can all impact having a robust network of providers for mental health services. So moving on to the actual reimbursement, the provider reimbursement, it's not really straightforward because you can't take, say, a psychiatrist and say, does the psychiatrist get paid the same as a surgeon? That just wouldn't make sense because there are all these variations, such as, they would have much different professional liability insurance rates, practice expenses. The surgeon likely has to have certain equipment in his office, the time, the technical skill, the mental effort, the judgment involved. All these things are things that are important when you think about what is a reasonable rate for these specialties. So therefore, we need a benchmark. And Medicare reimbursement systems really, it provides the perfect benchmark. It's developed using a highly detailed scientific process so that it can be resource-based. All those things that I just mentioned, like, education, practice expense, liability insurance, all those things for this specific specialty are taken into account. And the way that they approach it, just like mental health parity, needs to be comparable, and it's developed consistently across all specialties and services, so the answers, the rates are not identical, but they're developed in a comparable way that leads to a fair result. The Medicare rates are expected to be similar to the prices that would be paid in a competitive market in which prices reflect resource requirements. So it's just a reasonable rate that provides a benchmark. And so we take mental health services and we compare it to the Medicare rates. And then we take the physical health services and we compare. And then we look at the ratios and we say, well, mental health was paid for, at 1.6, or usually it's more like 0.9% of Medicare rates, but the physical health was paid at twice Medicare rates. And then you would have a red flag. Kind of like this scenario. This is specifically the inpatient services. And so in this example, they're paying for physical health inpatient services at twice the rate as they do for inpatient psychiatric services. And this isn't comparing the two directly. This is comparing it to the Medicare rates. And so this definitely is a red flag. This is looking more specifically at the professional services. And again, because of all the resource utilization factors that go into it, you need to look at the specialties each individually so that you get the proper ratio when you're looking at the Medicare rates. And here, almost all of the med-surgical specialties are paid at quite a bit higher than Medicare rates, whereas the psychiatry ones are paid pretty much right at Medicare rates, with the exception of a couple. So the previous slides definitely bring up some red flags. So at that point, when you get these types of results, you want to shift the burden then to the carrier and say, did you develop these rates at using a comparable way? Did you use some sort of analytic formula that you applied the same way to mental health as you did to the surgical services? What I find interesting is that the final rule, the final mental health parity rule, it specifically says that you can consider a wide array of factors, and then it lists these exact same ones. And so frequently I'll see these exact same ones listed in the policies and procedures for carriers with regard to provider reimbursement. The only trouble is they don't say how they're applied. And so it's great that they're using these factors, but if they're using these factors and they're still coming up with these disparate results, and they can't say that these were each used in a comparable fashion, then it's a compliance issue. So as I alluded to before, we see the red flag. We'd want to look, really go into the weeds with the policies and procedures. We'd want to, ask directly. It's some interrogatories where we say, do you have an analytic framework? Do you have a formula that you use those factors when you came up with your provider reimbursement rates? Oftentimes there'll be some disparity between what they'll provide on a document of their fee development, fee schedule development, but then they want a certain provider, so they'll negotiate differently with that individual. So you want to look at both. And then, of course, dig deeper. If they say, well, we paid the mental or the medical surgical provider more than you'd want for market supply issues, then you'd want to dig deeper into those types of issues. Compare the supply of mental health providers to the med-surg specialties, look at out-of-network utilization. That's a really big one. That's one that's being observed more and more so in the literature. And we even go so far as to employ secret shoppers to call to see, are the mental health directories, are they accurate? If it says they're accepting new patients, do they really accept new patients? And how long do they have to wait? And then we compare it to other types of physical providers. Provider reimbursement is an evolving topic. I've noticed that it's getting much more attention, and the National Association of Insurance Commissioners just released more information about it and how specifically to measure it and look for those red flags. It's obviously very important for mental health parity and has far-reaching implications. If you don't pay enough for mental health providers, you're not going to have a robust network when it comes to having providers provide good access to services. And really at the core of all the NQTLs is this impacting access at all for mental health patients? Is this limiting the scope, duration, amount, ease with which they can, set up an appointment? So remembering that core principle of equal access is really key. So I always try to, even when I get in the weeds, I try to stand back and say, well, how would this impact a patient? And that's really what we're after. So I am so pleased that we were here today. Like I said, I think this topic is incredibly important given our current situation with COVID, and certainly back with the Spanish flu of, I believe it was 1918, that they saw a lot more mental health issues and people had needs, and we want to make sure that we have things in place to provide good access for folks reaching out. Thank you.
Great. Well, thank you very much, Valerie. Appreciate that presentation. And I thought I could ask one question before we go on to our next presentation. If you could tell us and viewers just how you went about calculating the Medicare reimbursement for the claims that you analyzed?
Well, a lot of it goes in, well, not a lot, everything that goes into the calculation of the Medicare rates is public information from CMS. And our data analysts took that information and then they put it into a SAS code that they could run it against things to get the proper rate. We did not include things like graduate medical expense or dish payments, because those aren't really things that you use when you're negotiating with a provider. They're, you know, things that you get as a result for other reasons. And so we just calculated the rates without including those. Really, that's about it.
Okay, so you basically accessed Medicare data from a public source and then applied that to the claims as best you could.
Exactly.
All right. Well, thank you very much.
Thank you.
Okay. Next, we'll hear from Marianne Evans on the topic of Oregon APAC, novel use of pediatric medical complexity algorithm. And Marianne is an analyst for the Oregon Health Authority and is involved in all payers, all claims projects, including leveraging race and ethnicity data from different data sources across agencies, calculating child medical complexity to identify children for care coordination, and healthcare cost trend analyses. So Marianne, would you like to share your slides? And very good.
Are you on mute, Marianne? Still not hearing Marianne. Anybody else?
I can't hear either. Yeah.
Can you hear me now?
Yes.
Excellent.
Okay. Sorry, I'm trying to share.
We can see it. If you want to,
See.
we see the file. There we go. That's now we're seeing it.
There we go. All right. Welcome. I'm Marianne Evans, and I'm an analyst at the Oregon Health Authority. And my presentation today is about the Oregon all payers, all claims data and novel use of a pediatric medical complexity algorithm. This is a small piece of a much larger project, and I wanted to acknowledge the folks that we collaborate with at the Oregon Pediatric Improvement Partnership at Oregon Health Sciences University. So a little background about the pediatric medical complexity algorithm. It's an algorithm developed by the Seattle Children's Hospital Center of Excellence. It's a publicly available algorithm. It's used to identify children by their level of medical complexity. And it's based on diagnosis codes and claims data, identifying 18 different body systems and whether those conditions are progressive or malignant. It's a valid and reliable measure with good sensitivity and specificity. And you can see at the bottom of the page, there's a link there, and that takes you out to a website with a lot more information about the medical complexity algorithm if you're interested. So this project, we're really trying to, what the intention was to provide the PMC status to Medicaid coordinated care organizations for their new and existing enrollees up to age 21. The idea is to help CCOs target services for care coordination and complex health management. Ultimately, it's to help CCOs improve health outcomes, particularly for children with medical complexity. Again, this presentation is a small part of a much larger project. One of those projects is an integrated care for kids grant, and PMCA will be used to help develop some of the core elements of that grant. But again, today the focus is really on the novel use of all payers, all claims data in the calculation of PMCA. So the all payers, all claims data really is an opportunity for expanding or calculating the pediatric medical complexity algorithm differently. Because the all payers claims data has commercial, Medicaid, and Medicaid payers data, it has inpatient, outpatient, and professional claims, and it has monthly enrollment data for all people who are covered. So it includes people who have no claims. APAC is different for calculating PMCA because it's typically, they only use, only hospital discharge data is used or only Medicaid data, so a smaller set of claims or only facility claims. So the idea, the opportunity with APAC is really to improve identification of children with medical complexity. So some of the things that APAC offers as a benefit is that it captures children who move in and out of coverage from uninsured to insured status and vice versa, and captures children as they move in and out of state. It also helps identify children as they move from one insurance type to another or move from one CCO to another. So as a little background, because I don't know, I doubt you know too much about Oregon and our all payers, all claims data, is that we have about 4 million people in Oregon and about 3.9 people are in APAC. And this chart shows year over year the population and the number of people in APAC. About more than 90% of the Oregon population are represented in APAC every year. More than half of the people in APAC are covered by commercial insurers. About a third are covered by Medicaid, and about a quarter are covered by Medicare. As you can see, there's overlap that people have multiple coverages at the same time or during the same year. About 15% of commercial, 20% of Medicaid, and 24% of Medicare have that double coverage. And you can see over time the impact of the ACA on enrollment and on coverage type. So again, because this is age specific, I thought it would be useful to show what the age of people are in APAC. You have up to about 25% that are birth to age 21, our target group. About more than half are age 21 to 64, and about a quarter are over the age of 65. And you can see that over age 65 grew as a proportion of the population in APAC over time. So again, this project, we evaluated many different models of cohorts for calculating the pediatric medical complexity algorithm. So we looked at different time periods. We took a cohort and looked back and forward at claims. We took cohorts and looked only backwards. We looked at different numbers of years of claims. We looked at different age cohorts. We looked at different age limits, and we looked at different enrollment requirements, just a lot of different modeling. So in the abstract I submitted back in the winter, we were focused on claims from 2016 to 18 and children up to 18 years old. But subsequently, we sort of settled on looking at APAC claims from 2017 to 19 and children up to 21. Now, to keep in mind that the 2019 claims are not final claims, but we wanted to use those claims so that we could provide the most complete and recent data to Medicaid CCOs. For those of you who know something about the PMCA, that you'd want to know that we're using the more conservative version. So in order to be identified as complex chronic, a child had to have more than one body condition and more than one visit per condition, or the condition had to be progressive or malignant. So the results of our calculation were that about 7% of the total population of children up to 18 had complex chronic conditions, 16% had non-complex chronic conditions, and 78% had non-chronic conditions. As compared to Medicaid, Medicaid had a little higher level of medical complexity. About 8% were complex chronic and 18% were non-complex chronic. For our more recent work, looking at children up to age 21, I thought it would be useful to sort of show over time the amount of people at the age and their coverage. So you can see there's a little over 500,000 people, up to birth to age 21 who are covered by Medicaid, and the same for commercial coverage. So the results of the second one, looking at claims 2017 to 19 and different ages in 2019. So you can see that 8% of the total population were complex chronic, whether that was age up to 18 or age up to 21. About 17% of the folks up to age 18 were non-complex chronic, and when you go up to age 21, that increases to about 18%. And like we saw before, Medicaid has more complexity. About 10% of the children have complex chronic conditions up to age 18 or up to age 21. Children up to age 18 are at 20% are non-complex chronic compared to 21% up to age 21. So that brings us to our discussions and some issues. I want to acknowledge that the PMCA scores in 2014 are higher than published rates. And that's because APAC has more claims and more payers. That would be one reason. Because we have, again, because most of the PMC studies really just use hospital discharge data or Medicaid data alone. Because you have all of the payers and all of the claims, you have increased ability to identify children with complex medical conditions. APAC also has multiple claims for a single visit. Because you have facility and professional claims, you're getting claims from both. So you may over-identify children with medical complexity. Another issue is that, unlike other studies, we have no continuous enrollment limitation. We wanted to provide as much data as we could to CCOs as possible. So we didn't want to exclude kids because they had short enrollment. That might lead to some over-identification, but we decided to err on the side of more information, not less, and more conservative in terms of identify children with medical complexity than less. It was more harmful not to identify children than it was to identify them. The other issue was we looked at a 3-year look back. Now, not every child in the cohort had 3 years of data. Some had 2, some had only 1, some had less than 1. But again, our idea was to provide the most contemporary data to CCOs as possible. I want to acknowledge again our collaboration with the Oregon Pediatric Improvement Project at Oregon Health Science University and some of the funding for these many projects that we're involved in, from the Lucille Packard Foundation, from the Ford Family Foundation, and from others. I wanted to provide some contact information. That's our website. I gave you the website where you can learn about Oregon's all payers, all claims data and request data. And if you want to contact me, there's my email and cell number. I also wanted to give just a little pitch. We had a great announcement this week that we linked Oregon's all payers, all claims data with death certificate data, and that data is now available for request. So I am open for questions. Thank you.
Thank you very much, Marianne. That was terrific. And I have a question for you. I understand from the description you gave of how you calculated the PMCA score that used largely medical claims data. Have you given any thought to what it would take to incorporate pharmacy claims?
Yes. Oh, I don't think I ever turned on my video, did I? I don't even know how. Oops. Nope. I don't know what can you hear me?
Yes.
Okay. I'm sorry, can you repeat the question? I was trying to figure out how to get the screen to turn on.
Oh, not a problem. So as I said, you used medical claims to calculate the PMCA score. And I was wondering if any thought had been given to incorporating pharmacy claims as well.
Yeah, pharmacy claims are not part of the PMCA, but we're certainly interested in exploring using pharmacy claims because children on long-term medications may not have an associated medical visit with diagnoses that would pick them up in the PMCA. But it's definitely a consideration, but we've not completed those analyses at this time.
Okay. And has the work that you've done for the Medicaid population in identifying those patients with the complex chronic conditions, has that information been used for care coordination for those patients?
For the commercial population?
For the Medicaid population.
Oh, it's part of the project, so that we will release those indices to the CCOs. As I said, it's part of a larger project. We have social determinants of health and a variety of other indicators that we calculate across the Department of Human Services and Oregon Health Authority. And we provide all of those flags and indexes to the CCO.
Okay, thank you very much.
Sure.
All right, why don't we transition to our last presentation. This presentation will be given by Meekie Shin on the topic Common and Unique Barriers to the Exchange of Inpatient and Emergency Department Visits Data in the Environmental Public Health Tracking Program. And Meekie Shin is an epidemiologist with the CDC Environmental Tracking Program and works on data quality and improvement of administrative data related to environmental health outcomes. So, Meekie?
Thank you. Can you see my screen?
Yes.
Good, thank you. Thanks for having me to presenting at NADO annual meeting. This work is collaboration work between CDC and NADO. I'd like to say thank you for Noam and Charles for this collaboration project. First, let me share some background of this study. The CDC Environmental Health Tracking Program, we annually receive hospital discharge data and emergency department visit data from 25 to 30 funded states. The data quality for these administration data is vital to inform public health science and practice. Here's the tracking state and partner we are working together. The tracking state submit hospital data as a single year file by data source and health outcome aggregate at the county level. Once tracking state program submit data to the tracking program, the data is used to calculate nationally consistent data measure to display on the national tracking portal. Here is an example of asthma hospital data on our tracking portal. Tracking program received 9 different data sets for the different health outcomes. The health outcomes include asthma, chronic obstructive pulmonary disease, carbon monoxide poisoning, heart attack, and heat stress illness. NADO has been a tracking program partner since 2007. Last year, tracking and NADO collaborated since 2007. Last year, conducted a need assessment survey to our 26 state program to understand their data process, challenge, and resource partnership to better utilization and accessibility of hospital data. The survey questionnaire was designed to access 6 aspects of hospital data. It includes data source, data user agreement, data attribute, obtaining data from the bordering state, data cleaning process, and data partnership. The survey questionnaire was sent to the 26 recipient program. CDC will share the lesson learned and our next step in this presentation. Here are some of our preliminary data outcomes. First, data source and timeline. Tracking states are required to submit the hospital data and ED visit data every year, and all 26 state programs currently receive or access to both inpatient discharge data. However, 4 states cannot access the ED visit data. In addition to the required inpatient ED visit data, some states have access to the observational stay data or all-player claim data set. It's not shown in this table, but 8 states receive data from their hospital association, and the other states receive data from their health department, agency, commission, or board. For our 2019 data call, most states were able to submit hospital discharge data up to 2018. However, a few states had a long lag time of over 3 years. Some states submitted 2015 or 2016 data last year. The lag time is even worse for ED visit data. 38% of programs delayed for more than 3 years. Data sharing agreement. The type of agreement varies by state. Almost 70% of tracking programs maintain a data user agreement or a data sharing agreement when disseminating data. 4 state programs have a memorandum of understanding, and 2 states require IRB review. However, the other 6 states reported that they maintain an inter-department service agreement, MOU, IRB exempt, etc. 4 states do not have a data access agreement in place. Most data user agreement or data sharing agreement are renewed annually or as needed based. 70% of state programs do not pay a fee to access the data, but 6 states spend more than $1,000 to access it. Data attribute. Regarding the protective health information, such as name, social security number, and address, 15 recipients received the record level data with PHI, and 7 programs received data without PHI. The scope of the data, 21 states receive a full record of all diagnoses. When we ask about the geospatial resolution, only 42% of programs have access to the street address or census tract information. However, 14 recipients have only access to the zip code level or other sub-county geography, such as a town home. Transfer cases are identifiable by most states. 16 states have a combination of variables to identifying transfer cases, such as age, date of birth, date of admission, etc. 6 states have the patient ID, and 3 states have the identifier or flag from the data provider. Only 1 state cannot identify transfer cases. For data cleaning, it's important to remove the duplicate. 12 programs answered that their data provider removed the duplicate, but 9 programs removed the duplicate in their end. Almost half of the program asked the data provider to clean the data by correcting error and resubmitting. 1 state said errors are not corrected at all. It's important to have data for the all state residents. However, only 3 states, Michigan, Kansas, and New Hampshire, receive full data from their all border state, and 6 states receive data from the some border state. Our survey found that some states pay to receive data on resident discharged from facility in bordering state. Data from bordering state typically have lag 1 or 2 years behind in state data collection. In summary, we have learned that there are common and unique challenges to exchanging the data between tracking program and state program. Timeliness, data granularity, and data cleaning, and acquiring data from the border state. To improve timely data submission, a standard data user agreement should be developed. In addition to the data layout and format, we strongly recommend that DUA should include a timeline for the regular sharing data. To access the critical data elements, such as protected health information or sub-county geographic information, we have learned that the state program need effective communication and engagement with their data provider. NADO can help if they need any help. In overall, once data submitted to the tracking program, we developed a standard multi-layer of data validation process. To improve data cleaning and validation process in the state program side, the state program are strongly encouraged to use tracking resource. We developed automated tools, document generic SaaS script, and technical support. Finally, to share cross-border health data, we need a good system such as state and territorial exchange of viral event like Steve. So finally, this survey really helped tracking program to understand the knowledge gap and barrier to our current practice on the hospital administration data exchange. This survey also informed the development research that can provide a solution for more efficient and timely data exchange. Finally, this survey can improve the ongoing data call process, including routine data validation and data sharing practice. Using the high quality hospital administration data, tracking program can provide timely and accurate data to the public. Here is some of the data tool the tracking has, for example, info by location, dashboard, and data explorer. Thank you.
Thank you, Meekie. I have a couple of follow-up questions. In the slide where you listed data attributes and the percentage of states that were providing data for each of the attributes, are there some data attributes that are more important, ones that you would identify as being higher priority that you would want to access to fill important gaps?
So recently tracking program, we focus our effort to making a sub-county level data measure. So far, we have a health outcome measure at county level or state level. Recently, a couple of states were able to submit the geographic level using the census tract level data. But this is depends on their access to the street data or sub-county census tract level from the data provider. So this is something we are highly prioritized to getting the more important data attribute in the future.
That's very helpful, thank you. With regard to all the efforts that you're making to improve timeliness and the granularity and even the quality of the data that you're seeking, has there been progress in following through on all the improvement actions that you've identified?
Yes, so tracking program, we recently developed a huge improvement in the data validation process. So we have a multi-layer data process. When data come into the CDC tracking program, there is automated data validation process, and we have in-depth data validation process checking the trend and the data descriptive statistic. And also we returned all data quality report back to the state to review their data set. But before we get in the data quality from the state side is more important. So we now trying to focus in more getting the more accurate data in the state side, like such as we mentioned about the border state data and then other like transfer data, removing the duplicate data, etc. Thank you.
Thank you. So Norm, do we have time to ask a question of all the presenters?
Yes, let's take a few minutes and do that.
Okay, so if all the presenters, yeah, great. Make yourselves visible. So just a couple of questions, and I guess we'll take, we'll ask the questions and take answers in the order that you presented. So we'll start with Valerie, then Marianne and Meekie. So I guess the questions that I have for all of you is, what has been the impact of the work that you've done? And particularly the impact on policy. How has it influenced policy? Valerie?
Well, the impact that it's had, we've helped several clients, carriers in different states, Medicaid agencies. We've worked with commercial carriers and Medicaid, and we've been able to go in and identify red flags with regard to provider reimbursement being inadequate for mental health, and in which case they were able to review their policies and procedures and make them more robust and come up with analytic frameworks that they could use moving forward that wouldn't necessarily make them equal, but would make them developed in a comparable process. And in doing so, I know there have been other folks who are going down the same road with using Medicare reimbursement as a benchmark. And I've seen this more and more in the literature, and NAIC recently released additional information, and I was happy to see that one of our reports was actually on their website is providing, you know, a methodology to, you know, go in and look at this and see if there's a problem to correct it. And then the GAO released a report not long ago talking about how important provider reimbursement is, and as far as states go, there are, I don't remember exactly, but the majority of states do not reimburse their mental health providers the way they should. So this is an area that can really grow and is being more scrutinized.
Yeah. Thanks for that. Yeah, we have similar questions here in Colorado, and I think I will probably be adopting your methodology and try it out here. So thank you for enlightening at least me and all our viewers. Mary Ann. Well, I'm not sure that we can hear you.
Can you hear me now?
Yes, yes.
Great.
Did you want me to repeat the question, or?
That's fun. The PMCA has been used before in Oregon, and we share it in a variety of reports internally and then with coordinated care organizations. So this piece of work really was about changing not the algorithm, but the data set, so that we could provide an index for many more children and look at different kinds of more claims and different kinds of claims than were looked at previously. And so, as I said, that the data gets fed to the coordinated care organizations and Medicaid, but it also goes into county reports and other statewide reports about risk factors and complexity for children.
Mm-hmm. That's great. Is the Medicaid agency going to be doing some evaluation of the impact of their efforts using your complexity score?
Yes, as part of the INC grant, there's a variety. As I said, it's early in the INC grant, and so they're putting together their metrics and plans, and that's a much larger thing. As a state agency, again, you know, providing the data to the CCOs on some sort of regular basis, and again, we haven't really established that. It's usually, in years past, it's a one-time annual report that the state does for the state, for children complexity for the state and for CCOs and for counties. But I think that there are hopes that we could provide the PMC index to CCOs on a more regular basis.
Thank you, that's great. And Meekie,
Yeah.
what has been the impact of your work, and particularly on policy-related matters?
We are trying to help in our tracking program to learn each other for what we can help to their exchange of the data and their challenge of the getting the their data. Since the tracking program is environmental health tracking program, so our administration data is very important data tool in our estimating the prevalence and incidence rate, linking to the other environmental exposure data, such as air pollution or radon or other exposure too. So providing the accurate and good timely data is our key of the success. So we are trying to providing to our survey summary to each grantee, our recipient program, so we can help each other to improve our data quality to provide better health outcome and the ecosystem to giving the more prevention approach and strategy.
That's excellent. Thank you so much. Thank you to all presenters. Really appreciate the time and the effort that you've made to put together such a clear and well-executed presentations. At this point, I think we have completed our session, And so once again, thank you presenters, and thank you for all viewers of this recorded session.
Thank you.
Thank you very much. Thank you.